Introduce one of our very distinguished speakers. Of course, you will know Laurent Garderet already from his papers. He made a very important publication for relapse and combination or treatment of relapse. So a paper which was actually, it's well cited and it's all over in the myeloma field. So thank you for coming and for telling us the newest investigations.
How do you make it? Here? Yeah. And the pointer? Is there a pointer? No. Okay. Okay, hello, good morning. First, I would like to thank the organizers and especially also Didger, Niederwieser, for inviting me for my first time in Lithuania, a very beautiful city. I didn't have the chance to really stay longer, but it's very nice. And this outstanding medical center, really, and fantastic new transplant team. I was asked to put into perspective autologous stem cell transplantation in myeloma, knowing that we have new drugs, very effective new drugs. So this is actually a real question. But don't be afraid, don't be worried. We will still need autologous stem cell transplantation, as I will show you, at least for the years to come. Maybe not forever, but for the years to come. Autologous stem cell transplantation is the first indication in Europe in myeloma. I mean, we in the registry, we have over 100,000 myeloma patients who had received autologous stem cell transplantation. So it's still a standard procedure. But as we already alluded to many times, we had very good new drugs, and especially in combinations. So the presentation will be in two parts. First, what is the role upfront and at relapse? So upfront, we have randomized major studies published, two, and a third one will be submitted this month, who give us some answers. First study was published less than 2 years ago by the Italians in the New England Journal of New England Journal of Medicine, and this is the schema of the study. Induction regimen, lenalidomide plus dexamethasone, so without any alkylating agent, and then either a double autologous stem cell transplantation, 2 times melphalan high dose, 200 milligrams per meter square, or what they called MPR, melphalan, prednisone, Revlimid, 6 cycles. And then they had another question, maintenance with lenalidomide or no maintenance. And to make a long story short, if you look at PFS and OS on this slide, you could see that autologous stem cell transplantation is much better, and this is statistically significant, both for PFS and for OS in the high-dose melphalan arm. In terms of maintenance, you do have a PFS advantage if you use lenalidomide maintenance, as it was published by the French IFM group and the American ones, but no overall survival advantage. So if we summarize very briefly this important paper, yes, for patients 65 or younger with myeloma, high-dose consolidation therapy was associated with longer survival and obviously more myelotoxicity than conventional dose therapy. And also, lenalidomide maintenance does improve PFS. So this is the first study, but I must say that MPR is not very much used nowadays because it has also some myelotoxicity. The same team did a very similar study with this schema, same induction, lenalidomide dex, 4 cycles, and then same double tandem transplant or CRD, cyclophosphamide, Revlimid, dex, 6 cycles. And then again maintenance and the build-up from the previous study, so lenalidomide plus prednisone or lenalidomide alone. And that was published this December 2015 and in the Lancet Oncology. And if you look here, you have PFS and here OS, and in blue, the transplant arm is superior to the non-transplant arm. And that is statistically significant both for PFS and OS, while for maintenance, if you add prednisone to lenalidomide, you didn't gain anything. So again, consolidation with high-dose melphalan and autologous stem transplantation remains the best option upfront for myeloma patients. And again, you have a higher toxicity profile. And now I would like to focus on the IFM study. And that study has been presented at ASH this last December, and this is the ASH presentation, and it will be submitted this month. This is a major study, and not only because it's French, but you will see we included 700 patients, 350 in 2 arms, and a follow-up of almost 3 years now. So this is to answer the question, again, do we still need to do autologous stem cell transplantation? And I believe we here have the best experimental arm because we are combining Revlimid Dex plus a proteasome inhibitor. And you know that this is today the best triplet combination that we can get. So this is the schema, VRD, and you mentioned the Boston experience with VRD. Paul Richardson has presented many years ago that VRD up front gives 100% response in myeloma patients. So VRD, 3 cycles, collect stem cells, and you do either a single autologous stem cell transplantation, single, right, 200 milligram per meter square, plus 2 cycles of consolidation with RVD, VRD, same as the induction phase, or 5 cycles of RVD, and then the same maintenance with lenalidomide for 1 year. The primary objective is PFS. Secondary objectives are quite common, but we are also studying, and I will show you a few slides on MRD, because you're very correct, we should target MRD nowadays in myeloma. Inclusion criteria are very standard. Status of the trial. You asked me yesterday, how many centers do we have within the IFM? Well, I was wrong, as I told you about 40. It's 69 centers, and in 2 years, we were able to include 764 patients. Patients' characteristics are the same in the 2 arms. In terms of high-risk cytogenetics, it's the same, about 17% of high-risk cytogenetics. If you focus on translocation 414, 17p deletion, and translocation 1416. In terms of best response, this is the first, and these are the first results. You increase with the transplant the CR rate of 10%. And if you look at least VGPR, so a decrease of at least 90% of the monoclonal peak, you are gaining 10% with the transplant arm. And more important, negative MRD. And this is again the next target in myeloma. You do increase considerably the MRD negativity with the transplant arm, the autologous transplant arm. And Josta Garten will address this issue, I'm sure, this afternoon, because allogenic transplantation has been so far the only way to get to that deep response. If you look at the VGPR rate according to the different phases, you see that after transplant, again, you increase dramatically the VGPR rate, and at post-maintenance, you have 10% more VGPR rate in the transplant arm. This is the same results according to the different age, ISS stage, and cytogenetic risk. And now, after the response rate, the primary endpoint, which is PFS. And with the median PFS, with the median follow-up, sorry, of more than 3 years, actually, you have a median PFS of 34 months in the non-transplant arm versus 43. So you're gaining 9 months of PFS in the transplant arm, and this is statistically significant, and this is shown here on this graph with a much higher PFS in the transplant arm versus the new drug combination. So the primary endpoint has been reached. We looked at different subgroups, and according to age, ISS, cytogenetics, response after induction, it is always in favor of the transplant arm. When we did a multivariate analysis, again, treatment arm is a major prognostic factors, as well as ISS, FISH prognosis, CR rate, and negative MRD. Let's go back to MRD, and you can see how predictive it is. If you have an MRD negative patients, you have a much better PFS, and it's even much better if this patient has had a transplant. Another endpoint, secondary endpoint, is TTP, time to progression. Again, the transplant arm is superior to the new drugs combination. Now, what about overall survival? Well, we didn't find any differences, but you know that in myeloma, we have excellent treatment at relapse, and therefore we need a very long follow-up to be able to show an overall survival advantage. So this is what we have currently. But however, when we look at the cause of death, even though the number of deaths is relatively small in the two arms, you have less patients dying from myeloma in the transplant arm compared to the non-transplant arm. In terms of side effects, of course, you have more myelotoxicity, but same thromboembolic events, same peripheral neuropathy, and same second primary malignancies. Therefore, this is the same message as the two previous papers. Autologous stem cell transplantation is feasible with an acceptable transplant-related mortality of 1.4%, increased rate of negative MRD, improved PFS, 4-year PFS, improved 4-year TTP, and for the time being, same overall survival. So today, the conclusion remains we should perform autologous stem cell transplantation to newly diagnosed young patients, at least until the age of 65. While we were doing this study, we did also two additional studies, MRD and imaging techniques, new imaging with PET, and I will show you very briefly some slides. So this, as you know, we have currently two different techniques to evaluate MRD in myeloma. So MRD before, as it was very well mentioned, you know, we should not be happy with the CR rate. This is not good enough. We should go much deeper. So this is the immunophenotypic CR, but we have to reach at least this molecular CR to hopefully have some patients, myeloma patients, to be cured. So what are the available tests? So we have the flow cytometry, and we have the next generation sequencing. So that's the same study. In this study, we compared the two techniques, flow and molecular CR, you see, after consolidation and after maintenance. Within that trial, half of the patients almost got a conventional CR, and we were able to analyze almost half of the patients with the molecular MRD. The median follow-up is 3 years, and this is the result by flow. By flow, you can see obviously that you need to be flow negative MRD to get a much better outcome in terms, this is PFS. Now we try to find the best threshold using the next generation sequencing, and you can see that the threshold, the optimal threshold is less than 10 times to the 6. And when you use this threshold, you can see that in each arm, it does have a major impact, the MRD negativity versus the positivity in both arms. And you will see again that in arm B, the transplant arm, you have a much higher MRD negativity compared to the, not much higher, higher compared to the non-transplant arm. Now we found that even flow MRD negativity, well, you still have actually positive molecular MRD, and so that it means that molecular is more sensitive. And in the end, in CR patients, those who have MRD negativity, molecular, you could see that 83%, this small portion of patients, they have an excellent outcome. And maybe among these patients, some of them are cured when they receive a combined new drugs plus autologous stem cell transplantation. And I will show you one. So this is the conclusion. MRD with NGS is feasible, highly sensitive, and 10⁻⁶ is the good threshold. And I will just show you one slide. When you combined MRD study with flow or next generation sequencing plus PET-CT, this is even better. If you have a negative MRD by flow and a PET-CT negative pre-maintenance, 89% of the patients have a negative, long-term negative PFS. So this is actually what we should target. Not only CR, but negative MRD, either by flow or by next generation sequencing, plus maybe negative PET-CT. So I think this is quite convincing that upfront we still need to do to all patients, all eligible patients, autologous stem cell transplantation. Now the second part, which is at relapse, and I must say that at relapse, it's much more difficult, much more convincing, mostly because we only have one randomized study that I will show you, comparing a transplant versus a non-transplant option, and therefore it's much more difficult to draw any conclusions. And we have, again, many more options at transplant. So that was already mentioned. Today, all transplant-eligible patients got a combination of an IMiDs plus a proteasome inhibitors plus steroids, a transplant, a consolidation, and some kind of maintenance. What are the options at relapse? Because, of course, we are targeting cure, but today, unfortunately, all myeloma patients at some point relapse. Well, we have the non-transplant approach, and I will emphasize on this part because we just have triplets, excellent triplets in that setting. We have a second transplant option, autologous, allogenic transplant, but I will not discuss. Josta Garten is the world expert and will tell you how we should consider this option. And we also have the new immune interventions, and you've heard of the monoclonal antibodies, the CAR T cells, and the immune checkpoint inhibitors, and they are very encouraging. This was published by Enrique Ocio in 2014, and I love these slides, and actually at the EBMT meeting, it should be even updated because we have even more options. So you see how many options we have to treat today. Besides high-dose melphalan, you know, you have, and mostly exciting are the monoclonal antibodies. Finally, you know, compared to, in opposition to lymphoma, we didn't have any effective monoclonal antibodies in myeloma, but now it has changed. And we have HDAC inhibitors and many other treatment options. But what remains for sure is, and that was described 10 years ago by Paul Richardson and Kenneth Anderson, the combination of an IMiDs, a proteasome inhibitors, and steroids. So in the relapse setting, we have many options, and many trials have shown that the triplets is superior to double new drugs. I mean, we published that with Dietger and Josta. First, that was the first ever study in the relapse setting. We compared VTD versus TD, and we were able to show a PFS of 18 months. Then we have the HDAC inhibitors, Vorinostat plus, Panubinostat plus Velcade-dex, 11 months. And here, and this is the next target in the relapse setting, the combination of carfilzomib plus lenalidomide plus dex with 26 months of PFS. This is a huge, major improvement in the relapse setting. And even in the good risk patients, it goes up to 29 months. So this is the best currently triplets that we have in the relapse setting. But we also have Lendex plus ilotuzumab, the new monoclonal antibody, and Lendex plus ixazomib, the oral proteasome inhibitor. And all these studies have been published and have been approved by the FDA and the EMA, or it's ongoing. So this is the CRD and carfilzomib, lenalidomide dex, and you can see it's highly superior to Lendex. Revdex plus Elo, and that was updated at ASH, highly superior in terms of PFS, right? And that has been published 2 weeks ago in the New England Journal of Medicine, and this is an excellent combination, all oral, Revlimid, Dex plus ixazomib. And ixazomib is very well tolerated, and actually that may be the drug to use in the maintenance setting. Much more better tolerated than lenalidomide. So not only you have these triplets, these outstanding triplets, but as I said, I will briefly mention the monoclonal antibodies, mostly targeting CS1 for hilotuzumab, and daratumumab. This is an outstanding drug against CD38, and I will not mention the checkpoint inhibitors, pembrolizumab, targeting PDL1. But again, it has new drugs, new cell therapies coming. You heard about the CAR T cells against CD19 that was published in the New England Journal of Medicine. And again, you have the checkpoint inhibitors. I will not go into details, but that is the future. Just few words. Daratumumab not only is acting with an immune-mediated activity, standard, complement, macrophage, NK cell directed, but also this is even better. The immune system is not working correctly, but when you had DARA, it stopped Tregs, Bregs, and myeloid-derived suppressor cells, and therefore it boosts the autologous immune system and has a better impact on myeloma. 2 studies have been published recently, phase 1 and phase 2, and that was combined and showed at the last ASH meeting by Usmani and I want to show you these results, because these people, they received for two-thirds, more than 3 lines of treatment, between 2 and 14 lines of treatment. Almost 80% had received a previous autologous stem cell transplantation, and less than half of them had also received carfilzomib. Well, with this very advanced patient population, 1/3 were still getting some kind of response, which is quite outstanding. And I like this slide very much. If you focus on those who respond, again, very advanced myeloma patients, 65% of responding patients remain progression-free at 12 months. You see? 1 year later, they're still alive. I mean, this is outstanding, and this is the overall survival in this, of course, a small patient population, but these were very advanced myeloma patients. So, outstanding triplet combinations, monoclonal antibodies, and I should emphasize that daratumumab is effective by itself. That is in opposition to hilotuzumab, who needs IMiDs to be efficacious. What about transplantation now in that setting? You know, well, this is the EBMT data. You can see that we are still transplanting in myeloma, and it's even increasing. Doing autologous stem cell transplantation, but also, to some extent, allogeneic stem cell transplantation. Mostly retrospective studies in that setting, salvage auto. The important point is this. As a prognostic factor, is the remission duration between the auto transplant and the relapse. And you are all aware that we should not do a second autologous stem cell transplantation if the patient is relapsing at least within 18 months from the previous transplant. So you should transplant only patients 18 or even 2 years relapsing after the initial transplant. So now let's move on to the only randomized study in the relapse setting comparing a transplant versus a non-transplant approach. So that was published by Gordon Cook from the Myeloma 10 group, the UK2 group. So PAD induction, selected patients more than 18 months from the previous transplant, and then a single high-dose melphalan versus cyclophosphamide alone. Well, I agree with you, this is not the optimal new drug use, but that's how the study was designed when it was first started. And in terms of time to progression, superiority of the transplant arm versus the non-transplant arm, and from the time of transplantation, you have a 19 months TTP, which is almost similar to the triplets, okay, with no maintenance, okay? And overall survival is superior. Now I will be very brief. So that was an algorithm published by the American colleagues, how to treat patients at first relapse post-autologous stem cell transplantation. So you have either the option of doing an auto-transplantation, or if you are high-risk disease, you may consider allogeneic transplantation. Allogeneic transplantation may still be an option, especially if you combine with the new drugs, but Josta will address this question. Remaining issues. We discussed, so this is definitely a very important point. Should we do maintenance with Revlimid? Well, maybe we should, but then if you relapse on Revlimid treatment, you will not be able to use any of the triplets that we just mentioned. So maybe, yes, do some maintenance, but maybe not until progression. And to which patients? These are major questions. we are still not able to overcome the bad prognosis of translocation 414 and 17p deletion. How can we improve the conditioning regimen? And again, what's the role of maintenance post-auto transplant? This is quite a busy schema, but to make a long story short, when you relapse, you have to induce a new remission, and then if you are high risk, your patient is high risk, less than 18 months, or fish high risk, you may consider allotransplantation. If you relapse more than, if the patient is relapsing more than 18 months, you may consider a second transplant, or you may consider using the new drugs, either combined or sequentially. And of course, as you mentioned, it's always better to include patients in clinical trials in order to move forward. So the conclusions are, in combination with the new drugs, it's not transplant without the new drugs, it's in all together. It remains a standard of care in first line. There's no question about it. It is a treatment option at relapse, but you understand that it's less obvious. But now, how are we treating myeloma patients in France? Currently, we have 2 trials, and it's upfront. For the transplant eligible, VTD plus or minus DARA, transplant, DARA or no DARA at maintenance, daratumumab, and for the unfit patients, Revlimid Dex plus or minus DARA. DARA will be added to all the combinations that we know in myeloma in the near future. So what will happen when we combine carfilzomib, excellent drug, excellent anti-myeloma effect, plus pomalidomide, very good drug, plus Dex plus DARA? Do we will still need autologous stem cell transplantation? That's going to be the next challenge. However, we keep improving. Patients are living better, longer, and this was updated by Shaji Kumar, and because they receive the new drugs, the new agents, but also because they receive transplantation, autologous stem cell transplantation. And I would like to thank you very much. I really enjoy your city, and I will be happy to answer to any questions. Thank you.
Very good talk. Excellent talk. Now I'm happy to start the discussion. So who has some questions? Please.
So you were proposing that the new therapies, which are coming, they in principle might help patients, and you will not need the transplantation, while others, they argue, okay, we have CAR T cells, which are coming also, What the role, of these cells? What do you think in France? Do you have a chance for CAR Ts, against myeloma? What already the first steps are showing some promise, which is even more expensive, than if you would combine these other two things.
In the daily practice, like tomorrow morning, when you see a patient, a myeloma patient, it is actually different from what we're talking today. CAR T cells, we don't have access to any CAR T cells so far. It may be the future.
2 years from now.
It may be the future, but it's as you are mentioning, it's difficult to make. You need specific facilities, and so it will not be for tomorrow. Monoclonal antibodies are much easier. The access, actually, we have daratumumab. You have BiTEs also, double actions. But for the daily practice, it's still a combination of a proteasome inhibitors, IMiDs, DEX, and autologous stem cell transplantation upfront for transplant eligible.
As far as I know, there is one combined study, Dana-Farber and IF.
It is the same study, actually, but
with delayed autologous transplant. In one arm, you have it after RVD, in one you do MEL 200 and the other is only with chemical consolidation and the cells wait.
Yeah, that's actually the
It's a nice concept, and I know many patients ask for that, but the reimbursement system doesn't allow to do it. So how is the situation with this trial?
So, well, how is the situation with this trial? They are ending the enrollment. This I think it's currently ending. But this is an excellent question. And while I was reviewing, looking back to the papers, and why not delay the transplant? Okay, for a transplant, but is it really needed up front? And actually, in the US, from what I heard, most do not perform transplant up front. They first start the new drugs, but they have much easier access to the new drugs. But in our study and the two others that I showed, the Italians, it happens that at first relapse, at least one third of the patients cannot get autologous stem cell transplantation because they are too sick or for any reasons. But the reality is that you're losing almost one third to half of the patients at relapse. They cannot get the transplant. So I think that's a major argument to proceed to transplant upfront right away. Maybe they have more aggressive clones, at relapse, but that's a true.
Anyway, this option should be included to regulations, I think, for the future. And taking this opportunity, one short question concerning adverse results with thalidomide maintenance in high-risk patients. There is at least one paper by Morgan, I think.
Yeah, you're right.
So what's the explanation for that? So patients who are on thalidomide and belong to this cytogenetic high risk, they do even worse.
Yes, you're correct. And, I don't know. I don't know the explanation, but for sure, in the maintenance setting, the interferon was good. It was effective, not only in your single patient, but in major studies was effective, but not well tolerated. That's the same with thalidomide. Most of the patients do not tolerate thalidomide in the long run. You have to stop it. And even Revlimid, and that's why probably we're moving to ixazomib. Ixazomib has an excellent toxicity profile. It's 3 pills per month, day 1, day 8, and day 15 every month, and probably that's the future of maintenance in myeloma.
Epigenetic drugs.
You're right. That's very much developed by Paul Richardson. So we were very disappointed with Vorinostat, as you know. But Panobinostat, maybe it's also an oral drug. You have some diarrhea, but it looks like it could be solved. It may be another option. You're right.
So regarding late autologous transplantation, there is also the rationale missing. Because what you want to have is killing as much cells as possible. So I don't think that this may be a good idea to wait too long and then make an autologous transplantation. But I'm very happy that now we are increasing the survival rates, and perhaps we are going to cure patients also. Yeah. That would be the wish.
Well, I'll make a comment on MRD. I fully agree that MRD negativity is extremely important, but the dilemma is that you do not get the information up front. So the fraction of patients that will not enter MRD negativity, you don't know which they are. No. So if you are going to treat them differently, how are you going to do that? Then either you have to treat all patients with a more intensive treatment, or what else can you do?
That's a very good point, but that brings us to the fact that myeloma is very heterogeneous. And currently we're treating all myeloma patients the same, and we should not. But we also have ongoing cytogenetic studies, and we will be able to separate myeloma patients in high risk from the beginning, in high risk to low-risk patients, and hopefully to treat them differently. Last week I discussed, Atal made a presentation, and he was asked, what about allogeneic stem cell transplantation in myeloma? And actually he mentioned that maybe these very high-risk patients, those who will not get MRD with bad cytogenetics, maybe these patients should get allogeneic transplantation.
You should know which they are from the beginning. That would have been better.
Yeah.
to start it up front.
Yeah, up front. Yeah.
Coming back to MRD, do you have any information? What is the time lag or the time period between a patient being MRD positive and then becoming clinically having myeloma? Because, you know, also the time, you know, the time period in between is important, because if you plan to do something, then of course you should know, should it be done quickly, or how are you going to deal with it?
Mm-hmm. Yeah, this is an excellent question. So you're mentioning how can we use MRD and treat relapse earlier in order to better control the disease. It is ongoing, actually, in France. You know, Hervé Avelloiseau is the leader, and we are sending him MRD every 6 months. Actually, that's what we've started, and we will hopefully be able to answer to your question: at what level should we start treatment, relapse treatment? I don't know.
Well, you know, the question is it of any necessity? Because in some diseases, as soon as you see MRD, then, you know, in a couple of weeks you will see ovarian disease. And in that setting, I think it is not worth doing it, because you will see it anyhow, and, you know, you won't gain anything. If it is different in myeloma and you have, let's say, 6 months, 1 year before the patient has ovarian myeloma, then it may be worth, of course, measuring it, right?
Yeah, correct.
So I know that now you have a next generation sequencing since 3 days. So are you planning to do some MRDs, Rolandus? So actually, could you tell him what to do?
Well, I can only tell you, I can put you in contact with Hervé Avelloiseau in Toulouse. He's the leader.
Would you start next generation sequencing in myeloma today, if you have a program which is starting?
It's ongoing. It's too early to say. I mean, if you have the technology, and if it's, I mean, it costs money. I mean, to send the samples to. Just talk with Hervé, and he will, for sure, in the future, it will be very important. I mean, the future, in the very short term.
So, any other questions or comments? If not, I would like just to mention that this meeting would not be possible without the sponsors. So please look at the exhibition going out, and I have to give the microphone to Ilona. She will tell you some very good news for
First
today.
of all, thanks to everyone who came to this stage to provide their speech and sharing experience with us. Special thanks for very, very nice lecture. It was really very impressive, and thank you very much. Now I would like to invite all participants to proceed lunch at the foyer, and our honorable speakers we would like to invite to 6th floor.